we have the bacteriostatic 0.9% saline. This is just one of your IV flushes. So what we're gonna do, we have it set up, it's all ready to go. The next point will be to prime our line so that we can get this connected to the patient. My recommendation would be to have 2 nurses check off on this and document who was involved in the setup and priming of a line of this EVD. All right, so we're gonna actually walk through this as we would in real life. So you can prime it one of 2 ways. You can prime it from the transducer side, or you can prime it from here. It doesn't matter which one you do. It's up to you. 6 of one, half a dozen of the other. What I will say is I would turn this lure lock off to the transducer. And again, just thinking of the off, it's preventing it from being open to air. We'll take this cap off. So whether you take this one off or you do that one, if this cap is contaminated, you don't palm it. Don't put it to the side. If you do, you need to get a new one. And I would say best practice would be to get a new one every single time, simply because we don't want to introduce, again, a source of infection. Just like I said, with this drop into the ground, we wouldn't want to do that. There's a risk for ventriculitis. Because this is a new setup, I'm not going to swab the lure lock, but if it was a new setup, or if it was not a new setup and this was, had been in the patient after it's completely set up and connected to them, you're going to want to get 3 betadine swabs, and you're going to swab the tip of this, not alcohol, betadine. You're going to swab the tip of this 1 minute each swab, so a total of 3 minutes. So we're going to connect this here. And there's a couple of ways, a couple of areas that we're going to need to prime the line. So we got to prime it to our limitor, and then we have to prime it to the tubing that's going to connect to the patient. So as you can see here, this is off to my syringe. It doesn't matter what I do, I cannot flush it, okay? So I'm going to need to fix that. So the first way to fix it is to turn the limitor. Okay, it's open now, and it's open to my system here, but it's off to that port there. Now, if I were to flush here, I'm getting nowhere because, again, this one's off. So you just need to think of the direction, pause, think of the direction of your lure lock. So I'm going to turn this one off to what would go to the patient so I can prime my limitor. So I'm going to do that. And you can see here, you can see, oh, I have to pull that, that's right. All right. You can see, drip, 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 drip. And I have a little bubble here, so I'm going to go ahead and get rid of that. If you do not fully prime your line, this could be enough to cause an airlock, and your EVD won't drain. Okay, so this is nicely primed here. Okay, so then now I need to prime the tubing going to the patient. So what I'm going to do is turn the lure lock off to the limitor, and now it is on to the patient. And you can see it here. Just like if you were priming an IV tubing. See if I can hold it such that you can see this. Maybe not. I don't know how well I can. We're going to pour things through here, and we're just going to push. Now I'm going to need another syringe. You can see that it's completely primed, which is what we want. Okay. And there's no air. You can always flush more if you need to. It's not a problem whatsoever. So we'll pretend that I just opened up a new package for this here. Before I do anything, I'm going to want to close the system. So we're going to close it here, closing it, and then we're going to close it to the transducer. Okay. Never want anything open to air whenever there's not something sealing it like this. So we're going to put this back on here. We'll pretend that's brand new and sterile. Okay, so now our system is completely primed. The one thing that I will point out to you is we have some saline in our limitor. It's imperative. So think of yellow as warning. It's telling you to pause and to think. So you need to pause and think, what direction is my limitor, my lure lock pointing? So it's pointing off to this, which is what we want. What we do not want is this. So it is completely open, connected to the patient, to a over 700 cc bag. Your choroid plexus, with your little things in your brain, your right and left lateral ventricle that produce CSF, only produce 20 to 25 cc's an hour, so once an hour, and at any given point in time, you only have about roughly 120 to 125 cc's or milliliters of CSF in your entire neuro axis, not 700. So if you drain a patient completely, one, it can be detrimental to their well-being. You can give them a subdural hematoma that requires emergency evacuation. So pause with these, take a moment, go through your safety check. So this here, we would not want. We would make sure that this is off. Now, I will say that because we primed our line here, I wouldn't want that saline just sitting in here, because once we start to record the amount of CSF put out, we wouldn't want to capture that amount. You just drain it, put it in the bag. But it's simply a drain, and then it's done. You put it right back up, okay? Now at this point, we're ready to go. This would then be connected, and if you are going to be the nurse that is handing this to the APP or neurosurgeon that just inserted the EVD catheter, what you're going to do is you're going to hand this to them in as sterile of a fashion as possible. And what I would do, you don't take the cap off, do not do this. You hand this to me like this, my ass is going to be you completely reset the system up. Sterility is of the importance with this procedure. So what you're going to do is you're going to hand it to them just like this, and then whoever the physician or provider is will then take this cap off and then connect it to the EVD, and you'll be good to go. And then just thinking of what an open system looks like, so let's pretend this is connected to a patient's catheter, which is in their brain. An open system is going to be such that I would turn this here, so you're going to turn your lure lock open to the transducer, because we want it open to this, because this is what's connecting to your monitor. And then this needs to be to the patient. Okay, this is good like this, because it's connecting this way here. That's fine.
It has to go all the way to the other side.
Which way? Oh, over here like this. Okay, disregard what I said. There you go.
Yes.
So it's open, and this is open to the patient. Okay, and then it'll drain however much you set your loop level at. And then hopefully it would stop. So let's say our loop level was at 10 of mercury. If the patient's ICP was greater than 10, so let's say it was 11, it would drain. If it was 9, it should theoretically not drain. And you can adjust your loop level by pulling these two levers up and down. And then I'm just going to point out that there is 2 different ways to measure loop. One is millimeters of mercury, which is on the white side here, and then centimeters of water, which is on the black tabbed area here. All of our neurosurgeons do millimeters of mercury, but just so that way you're aware there is a difference, and it's not a slight difference. So just when you're doing it, you want to make sure that you have it at the correct loop level, okay? Anything I'm missing? Mm-hmm. All right, so the only other thing I would say is you want to make sure that you level it. This is connected to the patient before opening up this entire system. Just make sure that you have it leveled, again, leveled to the tragus. And anytime you have an adjustment in the head of the bed, any adjustments with the head of the bed, you need to make sure that the system is locked, and then you re-level it every single time. Respiratory wants to come in and they want to suction the patient or do their treatment or their therapy, you need to make sure that someone's in here, a nurse, a registered nurse is in here monitoring this. You can see sometimes where if they suction and the patient coughs really hard, they'll dump CSF, because again, that increase in intracranial pressure from the bearing down can cause that. If x-ray, radiology wants to come in, they need to get a chest x-ray, whatever it might be, this needs to be locked. I would not leave this open. I would lock it, make sure that there's a registered nurse at the bedside with that patient. Whenever the imaging is done, at that point, re-level, and then you can open your system back up and you're good to go. If you do not have CSF put out, so 0 output for 1 hour, you need to call neurosurgery APP and say, hey, I'm just letting you know I haven't had any output of my EVD. If you have more than 20 cc's or 20 milliliters of output of your EVD in 1 hour, you need to call neurosurgery. And remember, your body can only produce about 20 to 25 cc's of CSF in an hour. So we're just wanting to keep a balance. Sometimes we'll do something, sometimes we don't. There's a lot of critical thinking that goes behind it. And then the other point that I will make is ICPs. So if the ICPs are over 20 and sustained for 5 or more minutes. So if you have an ICP of, let's say 25, and it's sustained for more than 5 minutes, you need to call us. Critical thinking on your part to also consider, let's say respiratory was suctioning the patient and their ICP spiked to 30 but then came back down. Well, it's because they were suctioned. I don't expect you to get into the nitty gritty or the granular of that. What I really want you to think about is, okay, when do I call neurosurgery? So ICP is greater than 20, sustained for 5 or more minutes, and then an output of 20 cc's or 0 in 1 hour. Those are all reasons. And sometimes it could be that the tubing needs flushed, sometimes the catheter needs to be positioned in the patient's brain or the ventricle. Another point that I will make is you are not to flush this system. Once you can flush it, wonderful, it's not connected. Once it is connected to the patient, you are not to flush this at all. That has to be an advanced practice provider, specifically with neurosurgery, with those privileges, or a neurosurgeon. Otherwise, if you start seeing a lot of sediment, you can see with blood, if they have an IVH or intraventricular hemorrhage, intraventricular hemorrhage, sometimes the blood can form here and can cause a clot and you have to flush it out. But just know that would be a reason to call us as well. All right, well, I wish you the best. Let us know if you need anything.